Well, so all women with hormone receptor positive disease are offered adjuvant hormone therapy now. Basically having estrogen receptors is the key, and progesterone receptors to some degree, regardless of HER2 status. I think that decisions about ovarian suppression or not are really based on clinical risk right now. And age to some degree. A 48-year-old is going to benefit a lot less from ovarian suppression than a 36-year-old. Should 35 be the cutoff? Probably not, because it really has to do with your ovarian reserve. So young women are going to achieve more benefit and have more side effects than older women. How we decide on use of tamoxifen and aromatase inhibitors, again, has to be very much individualized. Looking at expression, gene expression tests to try and decide this, really, we have no data to suggest it makes a difference. In fact, in the trans-ATAC trial, actually I think it was the whole ATAC population, they looked at the 21 gene recurrence score and found that, if you had a higher score, you had a higher risk of recurrence, and a lower score, you had a lower risk. Most of those women were postmenopausal. Actually, all were postmenopausal in one way or another, but the median age was in the mid-60s, 62, and they most didn't receive chemotherapy. So it's not really a comparable population. But the recurrence score was not able to differentiate between the benefits of an aromatase inhibitor versus tamoxifen in that patient population. There's also a lot of interest now in trying to assess which women are at risk for late recurrences, and the breast cancer index, the risk of recurrence score, those as well as the 21 gene recurrence score have all presented or published data suggesting that these tests might be able to differentiate women who have a higher risk from year 5 onward versus those who do not. We don't know if that's going to help us select the women who benefit from therapy. That's one missing hole, and hopefully we'll have some data on that sometime in the not too distant future. There's a little bit of data from MA17 with the breast cancer index that I think is quite intriguing and suggests that potentially women who have these higher scores will benefit from longer duration hormone therapy, and potentially in the future we'll be able to incorporate those on a more regular basis into our practices.